Today we are beginning with postpartum period, where we start first talk about the lochia. At least we all need to know about the various lochias, and then the time duration that we expect the lochia to last for, especially when it's last, or which one comes first, and what is the color. At least we need to know the color. The reason is that if someone goes home and then after a certain number of days, the person is still presenting with a certain amount of discharge or a certain amount of drainage that is bright red in nature, and it's past 3 days or it's past 3 days postpartum, then it should tell you that the individual is still bleeding. And that I made mention that when you are checking for postpartum hemorrhage, one of the key things you check for is the number of time the woman is changing her pad. So in your questions, you see that it says that the woman is changing pad multiple times in an hour or within the first 15 minutes, the pad is completely soaked or gives a percentage as 100% soaked. And that means that the woman is actually bleeding. You will need to report that to the healthcare provider immediately. So here we start with the lochia, where it has to do with discharge from the uterus that consists of both blood from the vessels of the placenta site and that of debris from the pseudia. So we have both blood mixed with debris coming out. Of course, I mean, it has to come out from the uterus so that, I mean, then it's a natural process, but the interest has to do with the amount of the drainage and then the consistency of it. Is the color staying the same, or the color keeps changing, or the color changes? So the first drainage that the woman is supposed to come out from the woman or discharge just after delivery is the rubra. So the rubra has a bright red discharge that occurs from day 1 to day 3, or from the day of delivery to the day 3. That is the time duration or the duration within which we expect to see rubra. If after 3 days, a woman is still presenting or complains of having discharge that looks like rubra, or describe her discharge to you, and it is rubra in nature, you know that it is not normal. So you need to report that to the healthcare provider. So as the days goes by, or as the woman transitions through the postpartum period, you expect especially the color and the amount the color has to change, and the amount of the discharge should also decrease. Okay, so in the initial stages, the amount might be, in terms of the volume of the discharge, might be more, but as time goes on, then you see that the amount of the discharge has to reduce or has to decrease. And that is what will tell you that the woman is recovering as expected. So from rubra, you have to go to serosa. So you say rubra is red. Okay, rubra is red. So R, red. If you want to remember this easily, you use the R, which is rubra, which is red. And we say that it's from first day post-delivery to day 3. Then when you take the serosa, so serosa also has a brownish pink appearance, or you can say serosa is pinkish or pink in nature. So the serosa will have a brownish pink discharge that also should occur from the 4th day to the 10th day. So between day 4 to day 10, we expect that the kind of discharge from the woman to have a brownish pink appearance. So if you have any other kind of discharge or drainage coming from the woman, and it is not brownish pink in nature, then it means that you need to report that. Okay, you need to monitor and report that. And at this point, the amount should also reduce in terms of the amount that will be coming. It should also reduce. It shouldn't be more than the rubra, and then it should not also be equal to rubra. As I said, we expect that as the days goes by, the amount should decrease in nature. Then the last one is alba. So we say alba is albino. So alba, we know albinos are white, okay? So alba is albino. And if you want to remember the last one, which is the alba, it is albino, will have a white appearance, okay? So alba is white discharge that occurs from day 11 to day 14. So after day 14, which is 2 weeks, literally we should see that the discharge or the lochia should stop. Okay, when you are monitoring lochia, another important thing you should also look out for is the odor. Does it have any bad odor which could indicate or which could tell you that the woman is experiencing probably postpartum endometritis? And then you might need to report that to the healthcare provider. Infection and maybe antibiotics will be started. So like I said, if you want to remember alba and then the color it will present, we say that alba looks like albino and that has a whitish appearance and the amount should be very scanty. The woman should not be presenting with huge amount of drainage between day 11 to 14. Okay, so these are the various discharges that we expected to come from a woman in the postpartum period and the various colors and the duration that the fluid or the discharge should also last for. The next problem in the postpartum, if you have an input you want to make here, you can bring it on board, or if you want to ask a question, you can duly raise your hand using the raise hand button, or you can unmute yourself and then you come on board with your issue. If I'm talking and then you feel like I'm probably running faster, you should just draw my attention to it or just ask me to repeat, okay? And I'll gladly do so as well. All right. Then we also talk about some emotional changes that will happen or take place during the postpartum period. We have postpartum psychosis, we have postpartum bliss, then we also have postpartum depression. The most serious ones are the depression and that of the postpartum psychosis. You know that if a woman goes into postpartum psychosis, the woman becomes a threat to even the child. And this woman can end up even killing the child or taking the life of the child. So when you are monitoring, since I have, okay, someone too has brought something in the comment section. Now, if you want to remember, use the country Republic of Saudi Arabia. So the rubla will be Republic, S will be Sarosa, Arabia will be Alba. Thank you for that. Okay, so we have the postpartum emotional changes. The first one we talk about is the postpartum bliss, which is quite common or normal. And when someone presents this kind of symptoms in the postpartum period, the only thing you need to do for this person is to show some emotional support to the person. Especially, you have to look at the support system of the person, and then you have to encourage them, allow them to come closer to the person. You know, when you talk about some of the psych issues, it will say that allow the woman to voice out their difficulties and show empathy whilst you are caring for them. So for postpartum bliss, it is not, I mean, it mostly resolves within 2 weeks by itself, no medication. It's just, I mean, providing the needed support to the woman and the woman will be okay. So this will happen from 2 to 3 days in the postpartum period. And like I said, it will resolve within 2 weeks. The symptoms that the woman will show for you to know that the woman is probably experiencing some form of postpartum emotional changes like postpartum bliss is that the woman will present with some form of anger. There's going to be anxiety. The woman is going to cry without any apparent reason. Then the woman will have some form of emotional labor. They will express a letdown feeling. Fatigue will also be there, because of probably anxiety and then the anger. There's also going to be headache resulting from some form of insomnia that this woman could have. Then there's also restlessness. The woman will also show what we call sadness. So these are some assessment findings that if a woman is presenting with postpartum disease, you would identify or notice. For your management, at least, like I said, it has to do with supportive management. You wouldn't need to do anything or medication unless the thing lasts for long and then the woman goes into postpartum depression or the woman starts showing signs of depression. And we'll talk about some additional assessment findings to some of this that will be added up for you to know that the individual is now showing signs of what we call postpartum depression. Like if the woman at a point starts selling her personal belongings, and we know that when you do psyche and we're talking about depression, you are looking at up for signs of suicide or suicidal ideations. So when suicidal ideations start coming in, you know that the woman has transitioned from the bliss to postpartum depression or postpartum psychosis, depending on what additional findings that has been added up to the assessment finding. So you have to provide supportive care. You also have to client family education. Support is very, very important. Then you have to do your, ongoing assessment for worsening symptoms. So like, that's why I was saying that if the woman do not get the needed and the appropriate support during this period, and the woman the woman continues to deteriorate, the woman ends up into postpartum depression. And for postpartum depression, support alone might not be enough. You might need to bring in your antidepressants, you might need to bring in your pharmacological management to help support this woman, and then other psychotherapy as well. So with postpartum depression, the duration is between 4 to 6 weeks. So like I said, if the woman do not get the needed support whilst the woman is exhibiting some symptoms of postpartum blues, the woman can deteriorate or the situation can deteriorate and the woman will end up having postpartum depression. So for postpartum depression, it will occur between or within 4 to 6 weeks, and it can stay up to 12 months, okay? And when it comes to the improvement, it can take up to 6 months for the woman in terms of the improvement, for you to see that there has been improvement in the woman's behavior. So there's a gradual improvement over 6 months if the woman gets adequate support and then treatment. For postpartum depression, for one of the things that could help you to tell that this person is having depression is the person is experiencing some form of suicidal thoughts, okay, or suicidal ideations. The person is exhibiting some suicidal ideations. And when it comes to suicidal ideation, one of the things you have to look out for, they will say if the person is now not showing interest in activities that they used to have much interest in it. So for instance, if the woman used to like, let's say, playing let's use, let's say football, okay, in quotes. Let's say if the person likes to play football, and now if you even talk about going to play football, the person is now even angry at you. Or if the person has a favorite toy, or let's say a favorite photography that has been hanged in her room, and now the person is trying to even pull the thing off, destroy it. If the person has some personal belongings like mobile phone, the person starts selling those items, it should probably click in your mind that this person is exhibiting some form of suicidal thoughts or ideas. So when you are reading your questions, these are some of the assessment findings or some of the things you should be spotting out, and it will help you to be able to know what kind of cases you are reading about. So for the depression patients, it's going to be the anxiety is going to be there. The patient is also going to exhibit some form of appetite changes, crying, sadness, difficulty concentrating, and then making decision, fatigue, they are unable to sleep. So because of insomnia, the woman will wake up being fatigued, then feeling of guilt, irritability, and agitation. They also have lack of energy, less responsiveness to the infants. They might even want to kill the infants, okay? And loss of pleasure in normal activity. So like that was what I was trying to explain with the football and other, activities I was talking about. And if the person is also showing signs of what I call suicidal thoughts, it should tell you that this person is probably exhibiting what you call postpartum depression. And in addition to the supportive care I talked about for place where you have to support the person, family, education, then you also need to bring in some pharmacological intervention. So probably your antidepressants might be useful here. Then the woman might also need some form of psychotherapy. The woman would need to join some groups that help with people with depression. In the States, they do have those kind of supportive groups that would help the woman with recovery. Among all the postpartum emotional changes, it is a postpartum psychosis that is very severe. And at this point, the person will start exhibiting some form of delusions, some form of hallucination. And so they will start exhibiting, if the woman start exhibiting these symptoms, then you know that the problem has become very severe. And these people, they become they are psychiatric emergencies, okay? And if you have to prioritize when it comes to prioritizations and you have these kind of cases in there, you might need to attend to them first because of safety issue. We know that when it comes to the NCLEX, we said that the NCLEX is an exam of safety. So safety first before you do any other thing, okay? So if you have, let's say, 4 cases or 4 clients, and you have a psychotic client in there who is very aggressive, you might need to attend to the person first, ensure safety of other clients before you even do any other thing. So safety first in the NCLEX. So you know that for postpartum psychosis, this will also occur within 2 weeks or within 2 weeks postpartum with this assessment findings I'm coming to talk about. The severity and the duration can also vary. So for someone with postpartum psychosis, you could have some form of confusion. There's also going to be delirium, some form of, altered level of, in terms of the level of consciousness of the person, you have the person exhibiting some form of changing, the mentation of the person. There's going to be delusion, there's going to be hallucinations, and then there's also going to be some form of manic symptom from the person. So if you have all these things or some of these assessment findings being exhibited by a woman in the postpartum period, you know that this woman is exhibiting postpartum psychosis. You will need to probably come in there, like I said, safety first. So with your management, these people are psychiatric emergency and they will need hospitalization with pharmacological intervention. Now, my general postpartum emotional changes management is that because this has to do with psych, or this has to do with, yes, it has psych. And in psyche, we say that if you are managing a patient, the first thing you have to do is that you have to acknowledge the patient. Acknowledge the patient feeling, demonstrate a caring attitude. Never ask why questions in psych. When you get a question, okay, therapeutic communication, we say that never ask a why question, okay, and never argue with the patient, okay. If you have an option where it looks like an accusation, or it looks like something like you are arguing, you need not to argue. You need not to also ask why questions in your psych. So you have to acknowledge the client's feeling. Then you demonstrate a caring attitude. You have to determine availability of family support and support systems and some resources that clients will need. Encourage and assist the client to verbalize their feelings. You have to monitor the newborn for appropriate growth and development. You also have to assist the clients assist the client's significant others and then other appropriate family members to discuss feelings, identify ways to assist the client, and then also all clients should be assessed for depression during pregnancy and in the postpartum period. So this one for all pregnancy women, in order to prevent this form of postpartum emotional issues, you need to assess pregnant women to identify their support system. And then if you notice any form of issue with the support system of the person, you have to intervene appropriately as well. All right. So that is it. I think someone was having issues with joining. I don't know if the person has been able to join now, but I think Yahoo will attend to her. So that is it for what we call postpartum issues, psychosis, depression, and the postpartum bleed. If you have any input, any question you want to make up, you can bring it on board as well before I proceed from here. So from here, we'll go into uterine atony. We talk briefly on uterine atony, talk about the management for uterine atony, and then very shortly, I'll bring out my questions. So when I bring my questions up, I'll view yourself and answer my questions, okay? Don't hide behind the phones and your PCs, okay? When it is time for you to also. Okay, so let's talk about atony. So in atony, we are looking at the uterus not contracting adequately. You know that in the during labor, you need the uterus to contract in order to help bring out the baby or the fetus. And just after delivery, you also need the uterine contraction to also occur to help with expelling or expulsion of the placenta. Now, in the postpartum period, you still need the uterus to contract. When the uterus contracts, it presses on small blood vessels or it presses on the vessels to cause vessel occlusion. And you know that when it comes to bleeding, when you are able to occlude a vessel, you stop bleeding. And so that is what you need uterine contraction, or that is why you need uterine contractions during the postpartum period after the placenta has been delivered, so that it will help compress on the blood vessels at the placenta site to help with occlusion of the vessel to stop what we call bleeding or to prevent hemorrhage. Now, you could have some people who have what we call uterine atony. And in uterine atony, what we meant to say is that the uterus is not contracting adequately. And so at the end of the day, the vessels that are supposed to be compressed in order to help it get occluded and then stop bleeding or prevent hemorrhage is not, or the contraction is not there. So at the end of the day, put the person at risk of what? Put the person at risk of bleeding. Now, there are some factors that could cause what we call uterine atony. One of them is when you have the bladder becoming full. When a woman delivers, so our midwives who are here, they can best say this, or they can best teach us this. When a woman delivers or in the postpartum period, you have to empty the bladder. You empty the bladder so that the bladder will not display what we call the uterus. When the uterus gets displayed out of its position or shifted to probably the side, you will have what we call uterine contraction being affected. So you have to do what we call assessment to find out to see as to whether the bladder is full or the bladder is empty. If the bladder is full, you have to empty the bladder. You have to also massage to see, okay, and then you have to also check to see the position of the uterus as to whether it is in the midline position. If it is shifted, it could lead to uterine atony. So on assessment for a uterine atony, the description that you will identify is that there is going to be what you call a bulgy uterus on assessment. It says that a soft or bulgy uterus noted on palpation of the uterine fundus. So when you do your palpation and then you notice that the uterus is soft in nature or it is bulgy and has been shifted to the side, it means that probably the bladder is full. Now that is what has shifted the bladder, causing it to become the bulgy. And that is what probably is also causing the uterine atony. So what you have to do is that for your interventions, you have to massage the uterus. When you identify a uterine atony, you have to massage the uterus until it is firm. Empty the bladder, okay? So the first thing when you get a uterine atony question, check to see in the assessment findings if it says that the uterus or the bladder is full. If the bladder is full, the first thing you do, or the first thing you have to do is to assess to see if the bladder is full. If it is full, you empty the bladder. Then you do your massaging of the uterus to ensure it is firm or until it is firm. You notify the healthcare provider after all these interventions has been taken. So notify the primary healthcare provider if intervention do not resolve the atony, because this could be an indication of what we call hemorrhage, or it could lead to hemorrhage. And probably maybe further interventions will need to be taken in order to help resolve what we call the situation. So that is also on uterine atony, just briefly on it. So in uterine atony, you can't forget the bulgy appearance of what we call the uterus. You have to remember that. And you have to remember that you also need to do bladder assessment. And if the bladder is full, you empty the bladder. You massage what we call the fundus, or you massage the uterus until it is firm. And then you have to notify your healthcare provider as well. The next thing we talk about is hematoma. When I'm doing hematoma, I talk about hematoma and laceration together, even though I do not have laceration here. But laceration and hematoma, mostly it is mostly the same, or what the circumstances that will lead to hematoma or vulvar hematoma occurring and then vulvar laceration probably occurring is quite the same. So for laceration, the cause of vulvar laceration mostly happens when probably during delivery, and then you needed to do some form of episiotomy, give some small episiotomy in order to help probably with maybe it was a macrosomia, or the baby is big, or probably the head will find it quite difficult to come through. So you needed to give some form of cut in order to assist with it. And so with laceration, the amount of, or in terms of the bleeding, sometimes I saw a question on it, they were comparing the bleeding or the color of the blood that will come out for what we call a hematoma and that of laceration. And for a laceration kind of bleeding, because if there's, so someone is asking which one you do first, between massaging and emptying the bladder. If in the assessment it says that the bladder is full on assessment, then you do what we call, you empty the bladder first before you do your massaging. Okay, so you will be your massaging, sorry, you're emptying the bladder first before you do your massaging. So you have to understand that when it comes to laceration, laceration will have a bright red discharge, or the blood that will come out will have a bright red appearance because the blood is not staying. But you know that in hematoma, you have an accumulation of the blood. And when the blood stays there, probably we all have seen what we call a hematoma clot before. You see that it will have a dark red appearance, or the appearance will be dark in nature. It will have a dark appearance in nature for a hematoma. But then for a laceration, it will have what we call a bright red in terms of the bleeding down also become. And a laceration will also not have a pressure, okay, in terms of the vulvar area. There is not going to be any form of pressure there because no accumulation of fluid there, or no accumulation of what we call blood. So there is not going to be pressure. But when you take a hematoma, in hematoma, there is going to be what we call pressure, because of pressure in the perineal area because of the accumulation of blood over there. So those are some of the few differences with hematoma and laceration in terms of how it will be described for you to know that this is a laceration, this is a hematoma. So let's go into hematoma. So for hematoma, there's going to be localized collection of blood in the tissue and can occur internally, involving the vaginal sulcus and other organs. The vulvar hematoma are the most common ones. The predisposing factor for what we call hematoma is when there is operative delivery with forceps. So for laceration, mostly it has to do with when you do a cut or you give epi's. But for a hematoma, mostly the problem has to do with, or the cause of it is when you use forceps assisted birth or during forceps assisted birth. That is what probably leads to the injuries, and then you have the collection of fluid there. You could also have some small hematoma. Usually it will absorb by itself, and then large hematomas might also require some form of incision to remove what we call the clot that might have been accumulated there. And then might also need some form of ligations to help stop the bleeding if bleeding is happening. We should also know that hematoma can equally lead to shock. And whenever you are looking at shock, you look at the assessment findings. That is what will tell you that someone is experiencing shock. So on assessments, you have to look for abnormal severe pain, not relieved with treatment or comfort measures, okay? Then we also have pressure in the perineal area, like I was explaining initially. There's also going to be sensitivity, bulking mass in the perineal area with discolored, what we call skin, inability to void, decrease hemoglobin and hematocrit levels. There's also going to be restlessness, changes in vital signs, especially when there's signs of shock or there's an indication that the woman is probably going into shock. There's going to be tachycardia, and then hypotension will also be there as well. Your management is that, for your interventions, are that you have to monitor for the pain, the pressure in the perineal area. Then you also have to monitor for the shock symptoms or signs of shock. Mostly ice will be used, or ice packs are placed at the area, and you know that the ice will help with what we call the controlling the pain or the pressure that is there. So place ice at the hematoma site. You administer your analgesics. You have to catheterize the patient to monitor or to avoid, if the client is unable to void by herself, and then probably even if there is shock, you know, like kidney might be infected or urine output might be infected, you might need to monitor the urine output of the client, IV fluids to replace fluid loss, then blood to treat any form of shock symptoms. Then you also have to monitor for infection. Very, very, very important. Your temperature, pulse rate. No, pulse rate will go up if there is infection. Temperature also go up. Then WBC count If there is severe infection, you expect at least your WBC count should be something around 15, 17,000 going. Okay. You know that something around 12,000 in a pregnant woman or a woman just after delivery is not really a cause for concern. But you still need to monitor your WBC counts, administer your antibiotics if infection or because infection are common, antibiotics are important. You might need to do incision and then evacuation of the uterus to also help with that. Oh, really? Then means today. Okay, so someone is finding it difficult to join. We've exceeded our limit for today, really. Oh, let me get my colleagues and see. Okay, so then let's talk about hemorrhage. Okay, in postpartum hemorrhage, listen to me. What you need to know is it spontaneous vaginal delivery or is it cesarean section? Know that the two have what we call there's difference in terms of which amount of fluid or which amount of blood loss will be classified as postpartum hemorrhage. Okay, if it is normal spontaneous vaginal delivery or if it is vaginal delivery, anything less than 500 or 500 or less is normal. So you only classify someone as having postpartum hemorrhage if the person is having more than 500 mils of blood or 500 mils of blood loss, 500 mils of blood loss, and then the person had a normal spontaneous vaginal delivery. That is when you need to know that the person is having postpartum hemorrhage. And when it is cesarean section, or if it is the person who had a CS, we expect 1,000 or more for the person to be classified as having postpartum hemorrhage. Anything less than 1,000 mil for someone who has or who had a CS done, we don't say the person is having is having a postpartum hemorrhage. Okay, so for CS, it is less than 1,000. Anything more than 1,000 is postpartum hemorrhage. Then for normal vaginal delivery or spontaneous vaginal delivery, we are looking at things or bleeding more than 500 for the person to be classified as having postpartum hemorrhage. So we should expect less than 500 for normal assessment findings. So that is on what we call postpartum hemorrhage. Then postpartum hemorrhage mostly occurs during the first 24 hours after delivery or later. Kindly hold on. Okay, kindly hold on for me. Let me ask my colleagues. I don't know whether are you with me or they are not with me here. Because people are fine.
I'm here. I'm
You are
monitoring
with
things.
me. Oh, okay.
Yeah, I'm monitoring
But
things.
today nothing can be done, right?
Come again?
I said today nothing can be done, because I don't know
Yeah,
whether you are
today,
checking the page top.
yes, I'm aware.
You
So
are aware.
yeah,
Okay.
so I
All right.
mean for
So for
yeah,
today, dear, maybe
yeah.
so we have to apologize on that, but probably it will be resolved, right?
Oh yes.
Yes.
Maybe the next
So
week it won't happen again. Okay.
all right. Thank you.
So anyone who misses anything, I mean, actually the network issues,
Okay.
maybe someone will replace you, but forgive us, okay? Maybe
Okay.
the next
Okay.
yeah, more won't happen again.
All right. So we are looking at postpartum hemorrhage, and we are saying that within the first 24 hours, that is when it mostly happens. But after 24 hours, even when the patient is discharged home, that is why you need to monitor the lochia. That's the importance of monitoring lochia whilst the patient goes home, or patient needs to understand the characteristics of the various lochias so that they will monitor the amount. Even when the patient goes home, the patient can still complain of having postpartum hemorrhage, and your patient might need to come back for further assessment and then interventions. So early postpartum hemorrhage will occur within first 24 hours. Postpartum can also have the late postpartum hemorrhage also happen beyond 24 hours. Then, whilst postpartum hemorrhage can occur anytime during the postpartum period, the greatest risk is during the first 4 hours. So you remember last week when I was talking about what we call the postpartum period, and I was talking, or the first 4 hours, or the stage 4, okay, during labor and delivery, the stage 4 talks about the last 4 hours, and we said that the first 4 hours after delivery is a stage 4, and that is the period that if the woman is going to experience postpartum hemorrhage, that is the period that it is likely going to happen. And during that period, we said that within the first 1 hour, you do 4 monitorings. And that means that every 15 minutes, you have to monitor the woman, okay, within the first 1 hour, every 15 minutes, you do your monitoring. Then the second hour too, you do your monitoring every 30 minutes. So 2 monitoring. Then the last 2 hours, you do your monitoring 1 hour. So together you get 4 hours within the immediate postpartum period. And that is when you need to monitor the woman critically for signs of hemorrhage or signs of bleeding. Then the second greatest risk is also the first 4 hours delivery. So sorry, the first 24 hours. So after the first 4 hours, if the woman does not show any sign of hemorrhage, don't think you are done. You should still continue to monitor in the first 24 hours. And even after that, you still need to monitor for hemorrhage. The cause of hemorrhage, the major cause of it could be uterine atony. Remember, I was telling you that in uterine atony, you expect the small vessels to get to be compressed, okay, from what we call uterine contraction. But if uterine contraction is not adequate in the postpartum period and there is uterine atony, it puts the person at risk of hemorrhage. Then if there is laceration, hematoma could equally lead to it. Then retain placenta fragment. So that is why last week when I was talking about placenta assessment, I was telling you that you have to assess the various, or you have to assess the placenta to see as to whether the various fragments are intact. You have to assess to identify if all the vessels are intact. And I made mention that we have 2 arteries and a vein. And as if you want to remember, you see ever. Ever means that 2 arteries and a vein in the middle. So you have to assess as to whether all the placenta parts are intact and there is no any retained fragment of it. Then obesity also puts one at risk of it. Obesity itself is also even another risk factor for what we call giving birth to a macrosomia, or a baby who is big. And so if the baby is more than 4 kilograms or 4,000 grams, it is also another risk factor. You need to look at it and then probably monitor for hemorrhage whilst the woman is going through delivery. So for your assessments, it's going to be significant or persistent significant bleeding. So perineal pad is going to be soaked within the first 15 minutes. So that is why I was saying that within the first 15 minutes, you have to monitor for pad soaking. The pad is completely soaked. It means the person is bleeding. Restlessness, pulse rate will go up, all indication of hemorrhage or shock will also be there. Then there's also going to be weakness, some form of lightheadedness, dyspnea will also be there. We know that when we come to NCLEX, our main target is what? We want to use ABC. And so we say that airway first in anything that you do. You have to maintain a patent airway. So positioning will be very, very important here as well. Okay. So you have to ensure, you have to give your oxygen, notify the healthcare provider as well. Then you have to always stay with the client. Someone else might need to get the healthcare provider involved. Then you need to elevate the lower legs, or you need to elevate the legs to at least 30 degrees. So you know that we say that if someone is showing signs of shock as a result of bleeding, you have to elevate the lower extremities, and that will promote what we call venous return, or that will promote venous return and then help with cardiac output, or help improve cardiac output. So you need to know that you have to elevate the lower legs. The challenge is that if you have elevating the lower legs and then Lumbeck, let me bring this in. If you have elevating the lower extremities and you have put the client in a Lumbeck position, go for raising the lower legs. Okay, if you have both lower legs and then Lumbeck in one question, okay, and you have to choose, the appropriate position is elevating the lower extremities. But if you don't have the lower extremities there, elevating the lower extremities, and you have Lumbeck position, then you have to go for the Lumbeck position. But like I said, if you have the two and you have to go for one, the best will be elevating the lower extremities. Okay. Then you have to also check the uterus to see as to whether there is any sign of atony. If atony is there, we need to do the interventions for atony. IV line might be needed. You might need to give your uterotonic medication, oxytocin, prostaglandins as prescribed to increase uterine atony. So I think someone was asking us whether we give oxytocin in atony. Yes, you give oxytocin, okay, to promote contractions. Oxytocin is also useful in atony as well. Then you have to provide additional IV fluids and all that to replace what we call the fluid, because this is quite, you might need to give a large amount of fluid. So you have to use either 16 to 18 gauge IV catheter. But this is just something I want to bring in. If you are to give blood, okay, which catheter side or which cannula size we use for blood? We know that the preferred cannula size is size 18, okay. But if the client already has a 20 in place, okay, if a client already has a catheter or a cannula catheter size of 20 already in place, no need to change it to 18. But if you have to, assess a new IV line for blood, then you must use what we call catheter size 18 for adults. I'm talking about here. Okay. So that is just something I just want to bring it on board so that we can refresh our memory on that. Vital signs, very important. Catheterization, monitoring kidney functions and all that, blood administration and all that, you might need it. Then you have to also administer your medications to assist this. So we'll go through some of the medications, and then we might also get to understand that part. You prepare for surgery or other emergency treatment to help resolve the problem. Document findings, and then you prepare to send the clients to a critical care unit for management to also continue from there. So that is also on what we call hemorrhage or postpartum hemorrhage and then shock. The next thing I'll talk about briefly is on mastitis. And with mastitis, I'm not going to spend time on mastitis, very shortly on mastitis, that it is also one of the common issues or areas. Very simple, you'll be coming up across it whilst you are doing your questions or preparing for English. Here, it has to do with some form of infection, mostly colonizing what we call the breast, mostly results from what we call breastfeeding. If, let's say, there is some form of breaks in the skin integrity of what we call the areolar area of the breast, you have what we call bacterial invasion or bacteria entering through the cracks, and then leading to the inflammation and then the infection process setting in. One thing I want to talk about with mastitis probably might be the management, that when there is mastitis, you don't tell the woman to stop breastfeeding. For that one, you can't forget about it, that even if there is mastitis, the woman should still continue breastfeeding. And then if the woman cannot breastfeed, okay, you might need to decompress the breast milk. You might need to use a compressor to kind of express the breast milk for the baby. You know, when the breast milk is not expressed and then it's still staying in there, it still puts much pressure and then on the breast, and it still leads to what we call the pain. So if the woman cannot endure the pain from the sucking from the baby, then you might need to use a compressor to decompress the breast. Okay. So mastitis primary occurs primarily in breastfeeding parent 2 to 3 weeks after delivery and may occur at any time during lactation. Your assessment, of course, going to be some form of temperature changes around the breast, heat, swelling, tenderness, pain, and all that. There's also going to be temperature, flu-like symptoms. Your interventions are: one, hand washing is very, very important in managing mastitis. You have to always ensure that the woman ensure hand hygiene is very, very important over here. So instruct the clients, or instruct the clients in a good hand washing and breast hygiene. You know that when it comes to breast hygiene, we say that we don't use soap. Okay, never choose an option where it says that use, whether it says a harsh soap or a mild soap or whatever it is. You don't have to use soap on the breast to wash it, because the more you use soap, the chemicals on it can further cause the breast to become dry and then can cause some form of cracks, and that will equally enhance what we call the bleeding, the infection or bacterial invasion. So you have to ensure that you are only using, say, lukewarm water to just wash the place and dry it. Don't use soap on the breast. It promotes comfort. You apply some form of heat. Okay, should I say heat? Not heat. Let's replace the heat with warm compresses. Okay, let's replace the heat with warm compress. So apply warm compress to the sites as prescribed. Then you have to also encourage fluid intake at least 2.5 liters to 3 liters per day if it is not contraindicated. Lactation should continue or maintain lactation. So like I said, the woman will still need to continue breastfeeding. You encourage manual expression of the breast milk, or you use what you call a pump to express the breast milk every 3 to 4 hours. You have to encourage a woman to wear a supportive bra, avoid wearing an underwire bra, and then also avoid continuous pressure on the breast from tight bras and then infant carriage. Analgesics, as well as antibiotics, are all useful in what we call managing mastitis as well. I'm sure I am getting nearer to this part. Okay, then the next part is subinvolution. This also has to do with the uterus failing to return back to its normal size and shape. On assessment for subinvolution, you can have pain on palpation. You can also have the uterus becoming larger than expected, more than normal vaginal bleeding, because the uterus, it can also affect the contraction of the uterus. And then prolonged lochia will be there, or prolonged lochia rubra. Your interventions for subinvolution will be that you have to assess for vital signs of bleeding, uterus, and then the fundus. You need to assess to see if the uterus is contracting and then it's at the right position. You have to assess for uterine pain and then vaginal bleeding. Elevate the legs to promote venous return, especially when bleeding is occurring. Frequent voiding will also be important. You have to monitor the hematocrit and all of that. Then you give what you call methyl-gonavine. We'll talk about methyl-gonavine, but methyl-gonavine is used to, it provides sustained contraction of the uterus as prescribed, and it is also very useful for postpartum hemorrhage. But it has one thing with it, that if someone is having any cardiovascular issue, you can't use the methyl-gonavine. Okay, so we will talk about it very shortly, and we'll get to understand some of the issues with that very medication. Then you also have to monitor for any form of endometritis, where there's also good, it happens in the postpartum period. That is why I was saying that you have to monitor what we call the characteristics of the rubra or the lochia to see as to whether there is any form of abnormal drainage, or in terms of the odor, okay, or the smell of the drainage. You have to look at it and see if it has an abnormal odor. Then that will tell you that the person is probably having what we call postpartum endometritis. So there's infection of the uterus occurring in the postpartum period, mostly as a result of bacterial invasion of the placenta site. Then you also have that it could spread to the entire endometrium, could cause what we call acute, or it could cause peritonitis, and then could equally cause pelvic thrombophlebitis, and all these things can happen. It's an infection, so fever, chills, pulse will go up, loss of appetite or decreased appetite, headache, backbone, back aches. There's also going to be some form of prolonged, severe after pains. There's also going to be tenderness, large uterus, then a foul odor to the lochia. That is one of the key things that will tell you that someone is having endometritis. The lochia smell is one of them. So when you are reading your questions, you have to look out for all these things. Then WBC count likely also cause it's infection. You have WBC count also go up. So mostly with endometritis, the WBC count, when it's presented in the question, the moment, especially if it is case study, you go to labs and then you see that WBC is around 30,000 or 20,000, 25,000, thereabout, tells you the severe infection. So you have to intervene appropriately. It is infection, so vital signs are going to be affected. You monitor all of those things. You place the client in a foulest position to facilitate the drainage of lochia. You provide what you call private room for the clients because of infection and all that. You have to inform the client that it is not necessary to isolate the newborn. Instruct clients in proper hand hygiene, contact precautions. That is why the woman might need private room. So contact precaution is necessary because, I mean, because it's an infection, it can equally be spread through contacts. So you have to initiate contact precaution. Intake and output antibiotics also there. Comfort measures such as back rubs, position changing, pain medication, all could be there. Then you could also give your cytotonic medications, may be prescribed to help with uterine atony as well. The next thing we'll go ahead with it is pulmonary embolism. Now, for those who have watched my class on cardio, when you get to deep venous thrombosis, you get to understand that I did talk about Vagus triad. And in Vagus triad, we looked at 3 issues that put one at risk of having what we call deep vein thrombosis. And you can associate something like hypercoagulability there. And pregnancy is one of the contributing factors to hypercoagulability. And you can equally also associate pregnancy to after even delivery. You can equally associate what we call pregnancy or the postpartum period to vessel injury, where there's going to be clot forming. So when the clot forms, we know that the end of it is that the clots can travel through the vessel, get into the respiratory system or get into the lungs and cause what we call an occlusion of the lungs, leading to pulmonary embolism. And a pulmonary embolism patient for a pregnant woman, or if you get a pulmonary embolism patient, it becomes a medical emergency because there is going to be difficulty in breathing. Dyspnea is also going to be there. So when you get your questions and you are reading and you come across pulmonary embolism, especially for pregnant women, these people are high priority cases. You need to attend to them first. So passage of a clot, which often originates in the uterus or other pelvic veins, into the lungs, where it disrupts what we call circulation of blood. So, like I did explain how you could have pulmonary embolism occurring. Their assessment findings are that there's going to be acute or sudden onset of dyspnea with chest pain. So if you have a question where you say that a pregnant woman or in the postpartum period, the woman complaining of sudden chest pain and dyspnea, okay, the moment you spot this in your assessment findings or in your question, it should prompt you that probably it is a pulmonary embolism that you have come across. You could also have tachycardia, tachypnea, all as a form of compensatory measure. Cough and lung crackles could also be there. Hemoptysis, feeling of impending doom, is also another contributing factor. Your interventions are that airway first. So in pulmonary embolism, because the problem has to do with gaseous exchange being affected, your oxygen will be, high priority here, or oxygen, very, very important. Positioning, okay, you have to position the client with the head of the bed elevated. You monitor for what we call vital signs frequently, especially respiratory, and then assessment and that of the heart rate, breath sound, and all those things need to be successful. Then we know that these people are likely going to go into respiratory distress. So there's going to be signs of increasing hypoxia. If they do ABG for this person, you know that it's going to show what we call respiratory acidosis, or could happen out of it. Then you have to, IV fluids will be there, very important. You have to administer your anticoagulant as also prescribed. Then, so with the anticoagulants, heparin, warfarin, and then the other ones are all there. I think we need to revise on cardio. I did talk about the anticoagulants on cardio. So for those who are doing cardio, you can refer to my class on cardio. Like I said, on our YouTube page, you will get access to the cardio, and then you can watch the class on cardio as well. I went extensively into some of the areas as well. Then the same thing has to do with thrombophlebitis. So thrombophlebitis, thrombus is the clot. Phlebitis has to do with inflammation of the vessel. So when you have the clot developing in the vessel, it stays in the vessel for a while, and it leads to inflammation. So thrombophlebitis has to do with a clot that will form in your blood vessel. And when the clot stays there for a while or stays there for some time, it leads to inflammation. And that is what will lead to thrombophlebitis. So it could lead to a partial occlusion of the vessel, and it mostly occurs in the legs and can also be superficial, deep, or pulmonary embolism is the highest concern here, like I did mention. So increased blood clotting factors in the postpartum period places the client at risk of this. You also have early ambulation in the postpartum period or postoperative period after cesarean section is a preventive care. So that is why after any major surgery, we have to encourage the woman or the person to ambulate at least after 8 hours of the procedure. The woman has to ambulate in order to prevent clots from forming or clot from developing. Your assessment is that there's going to be some form of, palpable thrombus that feels bumpy and hard, tenderness, pain as well in the affected extremity, warm and pinkish red color over the thrombus area. It's going to be some form of body. Kindly mute out for us. It's going to be malaise, chills and fever, diminished peripheral pulses could also be there. Shiny, white skin.
I'm not the crate inside.
Then there's also going to be pain, stiffness, and swelling of the affected extremities. Now, when it comes to the management, specific therapy may depend on patient. Someone is unmuted. Let me mute this person up. Madam Bev, my own Beverly.
Hello.
My own beverage. Yeah, is there a question? Let me mute my own beverage. Okay. Elizabeth, I see you unmuted. Are you asking a question? Are you making an input? Okay, let me mute them. All right, so I've muted them. We can have a common class now. Hey, is my okay, so I can continue on now. Okay, but why did I stop the sharing? Okay, so your interventions is that you have to look at, I mean, the location of the thrombus, whether there's going to give or the healthcare provider will give some form of anticoagulant to help manage the clot. You have to assess the lower extremities for edema, tenderness, and all those stuffs. Then you have to implement bed rest. So when it comes to DVT and then the management in terms of the bed rest, it's not complete bed rest, okay? So at first, it used to be complete bed rest with the mindset or with the idea that when you allow the person to walk or when you allow the person to ambulate, actively ambulating whilst the clot is there, the likelihood that the clots can dislodge is high, leading to pulmonary embolism. But further studies are now showing that whilst the clot is there, if you continuously allow the person to maintain a complete bed rest, then that also means that you are still putting the person at risk of what we call DVT or more clots to continuously to form. Okay, so you have to implement bed rest. However, you have to allow what we call gradual ambulation. Okay, you have to allow gradual ambulation, or whilst the client is in bed, the client should ambulate or should do some form of movement that will prevent further clots from what we call develop. One of the key things that can cause the clot to dislodge is massaging the area where the clot is. So it says that you have to encourage the client to avoid massaging the area where the clot has developed. Okay. So you have to understand that yes, a client will need to ensure some form of bed rest, but not a complete bed rest. Okay, for clots or for thrombus or for DVT. Then you have to elevate the affected legs. You have to apply some form of bed cradles to elevate the weight of the bedding or the bed covers, okay? Because the person is already in pain, especially the affected extremity, you have to elevate the weight of the bed clothing or your bed sheets, let me put it that way. That's why the bed cradles are used. Then you have to never massage the leg. So the massaging is one of the things, the key thing that can lead to the clot dislodging. So never massage the legs. You monitor for manifestation of pulmonary embolism I talked about. Then apply hot packs or moist heat to the affected site as prescribed to alleviate discomfort. Then you have to also apply stocking, okay, supportive hose if prescribed. Now, when it comes to the elastic stockings, this is also something I want to say about elastic stocking. When there is active clot in an instance where the client is actively having clots, the stockings are not used. The reason is that if you use the stockings are likely going to apply more pressure that can lead to the dislodgement of what we call the clot. So mostly the stockings are mostly used when the individual is discharged home as a form of preventive measure to help prevent what we call further clots from developing again. Pain medication, anti-analgesics, and all that. Your heparin, I've talked about heparin several times, and then your warfarin. You know that heparin and warfarin can be used together, and because it's a postpartum period, you can use both. But if you are to give any of these in the pregnancy stage, you can't give warfarin while someone is pregnant. You might likely use what we call heparin. Then you have to tell the client about medication that contain aspirin, because aspirin is also anti-platelets, and also put the person at risk for bleeding if the person is using either heparin or warfarin. You have to advise the person with regards to the use of medication containing aspirin. So medication containing aspirin are not given to clients on anticoagulant therapy, because aspirin will also inhibit synthesis of clotting factors and can lead to prolonged bleeding time, increasing the risk of what we call bleeding as well. No, stockings cannot be used when DVT is confirmed, okay? Because when you wear the stockings, like I said, the stockings apply more pressure there and can lead to dislodgement of the clot. So stockings are mostly used when the client is probably going home after treatment. Never massage the leg. I've talked about it. So client education, never cross the leg as well too. Prolonged sitting should also be avoided. Avoid constrictive clothing. So all these are factors that will lead to more clots to develop, and massaging will lead to the clots dislodging. Know how to apply your, stockings, aspirin. Stop smoking because of the effect of smoking on, vessel constriction. Then you have to understand the importance of anticoagulant therapy. You follow up with care as well. That is the last part of, or the last thing I'll talk about from the first part of my class. So I've talked for almost half an hour and a half or so. So I would like to leave it here. We go through some few questions. So today we might extend beyond the 2 hours more, and then we might go into the medication. I would want to complete the whole thing today so that probably we can start something else again. So let's go through some few questions. My questions are not difficult, maybe 10 minutes for questions, and then we make progress from there as well. So if you have a question, you have an input, you have a clarification you want to make, I know I've bombarded you guys with a lot, so you might need to also come up with something that maybe you are still thinking about. It says that if probably what you want to ask, someone also wants to also ask the same thing, or what you don't understand, probably someone also don't understand and want to also ask about it. So come up with your questions as well. So the next is monitoring a client in the immediate postpartum period for signs of hemorrhage. Which sign, if noted, would be an early sign of excessive blood loss? One is a temperature of 100.4, that is 38, an increase in pulse rate from 88 to 102 beats per minute, a blood pressure from 130/88 to 124/80, then an increase in the respiratory rate from 18 to 22 beats breath per minute. So Tahiru, your hand is up. Mr. Tahiru, you can come on.
Okay, thank you, sir. Actually, my hand is not. I'm not going to answer the question. I'm going to ask and it's a question.
Okay, go ahead. Don't worry.
Okay, you talked about mastitis, and I've also come across somewhere that if a patient, or let me say a postpartum mother, has an engorgement of breast, they do put cabbage leaves. But I'm trying to, yes, I'm trying to find out the rationale behind that.
The rationale.
Please help that.
Okay, so yes, that is true. It says fresh cabbage leaves. Is that not the case?
Yes.
So the fresh cabbage leaves, when it comes to, yes, there's someone wants to answer all that. Okay, so this is some of these leaves, okay, they probably have some, should I say, anti-inflammatory effects, and then that's so one thing it could, one role it could play is that it could have some form of anti-inflammatory effect, okay, and that will also help with the inflammatory process or resolution of the inflammatory process. And then someone is saying that it is cool in nature, so it also helps manage probably the temperature changes around the area. But I think that the main use of it is that it will have an anti-inflammatory effect. Okay, that will help with resolution of the inflammation. Yes, and it is true. So when you are reading your question and they are asking about the use of what we call cabbage leaf, fresh cabbage leaf, it is also quite useful in managing it is also useful in managing mastitis. So that is it. So Mr. Sadiq, I don't know if I've been able to
Yes,
help
sir.
with it. That thank you for the input as well. Okay, on that. Yes, who is okay? I know you guys know this. You are answering in the comment section, but tell me, I want someone to say something on this. Just tell me why you're going for what you are keeping in the comment section so that we can finish and then move on to something. Yes, Madam Vivian.
Okay, so I'm going for number 2. An increase in the pulse rate. Yes. An increase in the pulse rate from 88 to 102 per minute. Because we know that normally when there is bleeding, there may be shock or hypovolemia. And when it happens that way, the BP normally drops, so we have hypotension, and then heart rate rather goes up. So looking at the blood pressure here, it's not down, it's not hypo. So I would choose the heart rate, which is higher than the baseline. Thank you.
All right, thank you. Yes, there's another hand. Sadiq, your hand is still up.
Yes, please.
Okay.
I think I'll also go for the 2 because physiologically, since the blood supply to the organs, or let me say the vital organs, are not meeting, the system by itself will try to compensate that by increasing the heart rate to meet the demand of the body.
Okay.
So I'm going for B.
All right. I think we can make progress. Thank you all for the input. So that is true. The 2 is the appropriate option here. If you look at the Mr. Kabiru, your hand is up. Oh, you wanted to also come in with this question?
Yes, no. Get the same answer, but then I have a question.
Okay, go ahead with the question.
Listen, this is my question. In a case where the heart is maybe the pulse is going up.
Okay,
Hello?
pulse is going up. Yes, I'm with you.
And then the respiratory rate also going up. Which one do you choose first?
So you have to look at which for what we call, if it is hemorrhage, I think pulse rate will supersede what we call the respiratory rate. So when it comes to the assessment findings, okay, one of the first thing that will first happen will be the BP, if it is hemorrhaging or if it is blood loss. Hemorrhage, I mean, hypotension will be the first indication that you spot out. So blood pressure will start dropping, pulse will start increasing to compensate for the loss before respiratory rates will also start altering.
Okay.
Are you getting me? But among boys, your heart rate, your blood pressure, that you see that there's a drop, a vast drop or a drop in the pressure, then you have what we call the heart rate trying to compensate for the change. Then followed by, because the respiratory rate will also be affected because the amount of oxygen that is being carried by the blood is also going to be affected. So that point, then you have the respiratory rate also going up to also compensate for the drop in the oxygen that is being carried by the blood. I hope you get me, Mr.
Yeah. Yeah. Okay.
All right.
Okay.
The next is preparing a list of, so you guys have already answered this question. I see answers in the comment section already. The next is preparing a list of self-care instruction for a postpartum client who was diagnosed with mastitis. Which instruction would be included on the list? Select all that apply. You wear a supportive bra. 1, 2, rest during the acute phase. Maintain a fluid intake of at least 3 liters per day. Take the antibiotics until soreness subsides. Continue to breastfeed if the breasts are not too sore. Then avoid decompression of the breast or the chest by breastfeeding or breast pump. So we have 1, 2, 3, 1, 2, 3, 5, 1. Okay, so I have different answers. Who is ready to tell us? Defend her answer or his answer here, because I'm having different answer selection. Others going for 1, 2, 3, 4, 5. Some are going for 1, 2, 3, 5. Okay.
Go.
Yeah, hello, madam. Go ahead.
My supervisor. Please, can you explain the 6? I'm a bit I don't really get
This is a
6.
question.
The 0.6 is something.
This is a question that you need to. How do you understand it?
Avoid decompression of the breast, chest, or breast or chest by breast, chest by feeding or oh, okay.
Okay. So you will come back to it. Don't worry. We'll come back to that option again. But Mr. Tahiru, you want to come in?
Yes, please. I'll go for 1. That is by wearing a supportive bra to support the breast. I'll go for 2. Rest during the acute phase.
Okay.
And I'll go for 3 because we said we should encourage the woman to take adequate fluid. So let's say it's at least 2.5 to 3 liters. So that is like 250 to 2,500 to 3,000. So I'll take that one. 4, take the prescribed antibiotic until the soreness subsides. I'll leave that one out because you don't have to stop it. You only follow the prescribed schedule by the healthcare provider, or you complete the course. You don't stop. And then I'll go for the 5. You continue to breastfeed. If the breasts are not too sore, you continue. And then I'll leave the 6 because avoid decompression of the breast. No, I will rather encourage the decompression. So I'll take 1,
so
2,
someone was
3.
asking, okay, so I want to also throw the question back to you, Mr. Tahiru. Someone was asking about the meaning of avoid decompression, or what the option says meant to tell. What do you think the meaning of the option says will be?
Okay, what the option 6 is saying is that we shouldn't, from my understanding, you shouldn't even encourage breastfeeding. Like do not express the milk.
The milk, okay.
So which is also contrary to the option what we just learned earlier. So we have to decompress it or we express the milk.
Okay.
So that's why I'm taking it out.
Okay. So our sister who asked the question as to what was the meaning of that exactly that is the meaning, that avoiding decompression means that you are not going to empty the breast milk. So in the long run, it is telling us not to even breastfeed the baby or not to empty the breast. Okay, so that is what it means. That we've learned, we all know that we should empty the breast milk, or we should encourage emptying the breast milk as well. So that is there. So we have 1, 2, 3, 5. You know, the 4 is a wrong option, and then the 6 2 is a wrong option. Okay, so that is that for this question. I'll do 1 or 2 before I move on to the last part of this class. The nurse is providing instruction about measures to prevent postpartum mastitis to a client who is breastfeeding or chest feeding the newborn. Which client statement would indicate a need for further instruction? I need to breastfeed or chest feed every 2 to 3 hours. I need to change the breast or chest pad every frequently. I need to wash my hands well before breastfeeding or chest feeding. I need to wash my nipples daily with soap and water.
Is it select all that apply?
No, it's only one selection. We need only one.
You breastfeed on demand, no?
Please, it's 4.
It's 4.
Which client statement would indicate a need for further instruction? And the 4 is the only odd thing, is the most odd here. I need to wash my nipples daily with soap and water.
Okay.
Or
Yes, it's 4.
Okay.
Say,
I need to
Alright.
breastfeed
Four.
every 2 1 is
say
correct.
amigo.
Yeah.
I need
hello.
to change my
Take
bra
it one after
parts
the other.
frequently. Okay,
Okay.
please, I'm on the floor. I
Yes,
need
yes,
to
continue.
breastfeed every 2 to 3 hours is correct. I need to change breast parts frequently. That one too is correct. It's just like changing your clothing or your braziers and whatever.
Okay.
It promotes cleanliness.
Okay.
I need to wash my hands well before breastfeeding. We said that it's a very good way of preventing mastitis and all that.
Okay.
Hand washing. So I need to wash my nipples daily with soap, and I think the 4 is the odd one here.
Okay. Okay. All right. Thank you. Thank you for that, Madam Caroline or Carolina. Give me the young boy, That's by the way. All right. Let's make progress. Okay. Thank you all for the input. So I think
Hello.
yes. Hello, Madam Julie. You want to talk?
So I understand 4 is the most odd one, but are we supposed to breastfeed on demand, or we space it 2 to 3 hours?
Okay, so
Flamingo.
yes, yeah.
Ideally, you are supposed to breastfeed on demand. But in case you are not doing the demand, the minimum time is between 2 to 3 hours. You should wake your baby to feed. Whether the baby is sleeping or what, it shouldn't stay more than 3 hours. Like a baby will be sleeping for 4 hours, 5 hours without breastfeeding. It's so wrong.
Okay.
So at least within 2 to 3, if you are not even doing the demand, or baby is not craving for, demanding for, you are not, at least by 3 hours, 4 hours, you should wake the baby, even if he's asleep. Wake him up and breastfeed.
Okay. So our mothers has come in. Okay. So let's go, and I have other things I want to talk about. So I will truncate with the question aspect.
Hello, sir.
Yes, hello, madam.
Yeah, just to add to what the sister just said.
Okay.
I also thought there was breastfeeding on demand, or I have been taught in nursing that you breastfeed on demand until I came across an NCLEX question where it said that you should wake the baby up between 3 to 4 hours, like she says. So it's very correct. So that notion of feeding on demand is not always true, especially the newborns, very fresh borns. You don't allow them to feed on demand. Wake them up. It was an NCLEX question. Thank you.
All right, thank you too. Madam Akosia, I saw Akosia's hand up. You also
I'm
have
the one who
something.
just spoke. Sorry.
Okay, okay. I wasn't checking from the lines as well. Thank you. So thank you.
Hello, I want to
Yeah.
add a little.
Okay, go ahead.
Yes. So if the baby is feeding on demand, you realize that the time interval will be between the 2 to 3 hours. So
Okay.
it still holds. Yes.
Okay. Okay. All right. So the idea is that at least 2 to 3 hours, whether demand or not demand, we should make sure we are breastfeeding the woman, the baby every 2 to 3 hours. That is the basic idea here. Okay. Any further inputs, addition here? All right. So let's complete maternity on medication, and we'll go through the medications as well. We try to catch up with at least the basic pharmacology in maternity, and then maybe I might not be able to do all. When you are doing your maths and you add the rest to it, okay? So we'll start with tocolytics, and we know that the tocolytics, they are used to relax the uterus, okay? When you have what we call excessive uterine contraction, or when you notice that, let's say, someone is exhibiting signs of preterm labor, or someone is showing signs of going into labor when the person is not due, and the healthcare provider probably needs to delay the labor for some time, then the healthcare provider likely will go for a tocolytic. And one classic example of the tocolytic that you come across it all the time is your max sulfate. So we'll talk extensively on max sulfate. We looked at what to monitor in max sulfate administration, and then some interventions whilst you give it max sulfate. We looked at your assessment, especially the deep tender reflex assessment in max sulfate administration. So the tocolytics, they causes uterine, produce uterine relaxation and then suppress uterine activity. It halts what we call uterine contraction and preterm birth. So when we're doing preterm labor, I think I did talk about it, that you will need tocolytics to kind of delay the labor for some time. When you are giving your tocolytics, the general interventions for your tocolytics are that you need to position the clients on the side to enhance placental perfusion and reduce pressure on the cervix. You have to monitor vital signs, very important. Fetal status, you need to also monitor that. Then you have to labor status frequently according to what we call the agency protocol. You have to also monitor for signs of adverse effects of the medication. Now, I talk about what we call max sulfate. I think another tocolytic that's also used is nifedipine, which is a calcium channel blocker, and it will also help suppress what we call contraction. If you are giving your calcium channel blocker, you know it's an antihypertensive. It also has effect on the pulse rate. So you have to monitor for hypotension, you monitor for decreased pulse rate and all those assessment. Even though I might not talk about that, but I'll talk extensively on max sulfate. You also have to monitor urine output. Very, very important if you are giving what we call max sulfate. Then you provide, fluid intake if that is prescribed. You have to offer comfort measures and provide some form of support to the woman. Then I'll move to max sulfate proper. So we know that max sulfate is a central nervous system depressant, and also it is anti-seizure medication. That is why if someone is having what we call preeclampsia or is having eclampsia, you have to give what we call max sulfate. The max sulfate causes smooth muscles to relax. And so if you are having what we call seizures, the max sulfate will cause your muscles to relax, and that will help to abort or will help stop what we call the seizure. The medication causes smooth muscle relaxation. Antidote to max sulfate is your calcium gluconate. You can't administer max sulfate without having calcium gluconate at hand, because in case there's toxicity of magnesium sulfate, you will need to give your calcium gluconate. So we should understand that antidote to what we call max of it is calcium gluconate. You know, we have a number of medications and their antidotes. At least that is your assignment for today if you don't know. So if you are new to it, and I know that by the time you finish the whole training or the NCLEX program, you might have come across all the various medications and their antidote as well, like warfarin, heparin, and other medications and their antidote. So stopping preterm labor to prevent preterm birth, although it is less commonly used for this effect as well. It prevents and then controls seizure in a pre-eclamptic and eclamptic clients. The adverse effects for max of it is that it produces what we call respiratory depression. Because it depresses smooth muscles, it can affect your respiratory muscles as well. So in max of it toxicity, one of the key things you have to monitor is the respiratory status. So you have to do your respiratory assessment. You have to look at the respiratory rate. Is it less than 10? At least if it is less than 10, it's cause for concern. And you have to make sure that at least if you are giving your max of it, you are maintaining your heart, the respiratory rate should be above 12. 12 and above should be the correct. I think 12 and above, you should maintain the respiratory rate above 12. Then, depressed reflexes. So depressed reflexes also has to do with deep tendon reflexes. I think 2 days ago, so I saw Ima sharing reflex assessment on the page. And I always, when I'm doing this, I say that when you are to assess for your reflexes, you have to label reflexes, or reflexes are graded from 0 to 4. 0 to 4 reflex grading means that 2 is the ideal reflex. Okay. So for instance, as I am here, as you are there without any issue with hyperreflexia or hyporeflexia or reflexes, our reflexes is 2, means that we have normal body movement without any form of decreased body movement or hyper body movement. So if you are having seizures, okay, if you are, especially if the woman is in a eclamptic stage and the woman is showing signs of seizures, it means that the reflexes are high, either 3 or 4. Now, if you give max sulfate, the effect of max sulfate is to bring the reflex down. So if you have a reflex of 4, or someone reflexes is graded as, let's say, 4, and you give max sulfate, you expect the max sulfate to bring the reflex down to either 3 or 2. 3 means that at least you have achieved a certain goal with your medication, and then you continue to monitor to see if it will drop back to the normal, which is 2. Now, if the reflexes go to 2,
sorry, okay.
hello, Madam Akosia, you have unmuted. So, Madam Akosia, kindly mute her for us if you can hear me. So we expect if the reflexes drop from 2 to, let's say, 1 or 0, it means that you are having hyporeflex. So 1 is hyporeflex, 0 is absent reflex. You are not, there is no body movement. Okay. So these are the reflexes and explanations. It's also going to be flashing, hypotension, extreme muscle weaknesses. It can also affect your urine output. So decreased urine output is also something you should monitor. So on assessment, if the person is producing urine or you are doing your urine output assessment, at least you should maintain it between 30 to 50 ml per hour. In other archives or books, you see that they will say 25 to 50 ml per hour, which is fine. Anything less than 25 per hour, 25 ml per hour is a cause for concern. Pulmonary edema can happen. You could also have elevated serum magnesium level as well. Then you should also understand that continuous infusion increases the risk of magnesium toxicity as well. So you will need to, the audio isn't working. Which audio is it from my end? High doses can also lead to loss of deep tendon reflexes, heart block, respiratory paralysis, and then cardiac arrest as well. You also have to understand that the medication is contraindicated in people who have heart block, myocardial damage, and then liver kidney failures as well. Then the medication can also cause some form of kidney impairment. That is why urine output monitoring is very, very important if you are administering what we call MAC sulfates. Interventions, I think I've generally talked about them. You need to monitor the fetals, do your assessments, monitor the fetal heart rate, note the baseline before you begin the therapy. And throughout the therapy, you have to monitor the fetal status as well. You monitor the fetal heart rate, vital signs of the mother as well, every 30 to 60 minutes, especially the respiratory rate. Then you have to monitor the renal status, okay? EKG for what we call cardiac function too will be needed. For magnesium level, you have to monitor the level every 6 hours, or if signs and symptoms of toxicity are noted. The target range when used as a tocolytic agent is 4 to 7.5. So that means that if you are giving magnesium, okay, I think the normal serum magnesium level is it 2.5 to 4.5. Stand to be corrected. Someone should verify that for me. But if you are giving magnesium, because you are giving magnesium, it means that you now look for the therapeutic level, and the therapeutic level should be between 4 to 7.5. After 4 to 7.5, okay, 1.5 to 2.5. Thank you for that. If you are giving your MAC sulfate, because now you are giving MAC sulfate, you now will not look at the 1.5 to 2.5. You now look at this range, 4.4 to 7.5, okay, if you are giving what we call magnesium sulfate. Now, the level that you use for your reference range will not more be the 1.5 to 2.5, but rather 4 to 7.5. It's just like when you are giving heparin and warfarin, you expect the PT and INR and then APTT to change if you are giving your medication. So the same thing applies here. If you are giving your MAC sulfate, you now look out for the therapeutic level of the client serum magnesium, which is 4 to 7.5. So if it is above 7.5, then it means that the client is exhibiting toxic level of the medication. You have to administer the medication via an IV pump, okay? Carefully, because you don't want to give the medication as a bolus, so you give it via an IV pump as well. And then you have to have your calcium gluconate at hand. When you notice that there is an overdose of the medication, you quickly have to give your calcium gluconate. You place what we call your resuscitation equipment on the bedside. You monitor deep tender reflexes, as I did explain, every hourly for signs of toxicity. Then urine output should be maintained at 20 to 30 ml per hour because of, medication, which could cause, because of the medication could affect the kidney functions. So you need to monitor that you are maintaining urine output at least 25 to 30 ml per hour. Then you closely monitor the client for signs of magnesium toxicity. You call the healthcare provider, or if the client respiratory rate are less than 12 beats per minute, then that could indicate that there's respiratory depression. So when you are giving your MAC sulfate, the target level for the respiration should be 12. If it goes less than 12, then it is a cause for concern here that you need to inform the healthcare provider on that as well. The next one I talk about briefly are the steroids for the maturity of the lungs, especially if you suspect what we call preterm labor. At least you have to give what we call your steroids to help with lung maturity or production of surfactants that will accelerate lung maturity and reduce incidence of respiratory distress syndrome. Then when it comes to the side effects of or the adverse effect, we know that steroids, if you've done endocrine, and I think endocrine, when you do endocrine, the first part of endocrine, we'll talk about steroids, adenosine Cushing's, and all that. So if you are giving steroids, if you want to look at the side effect of steroids, we know steroids will affect your glucose level, especially if you're having Cushing's. It will lead to increase what we call glucose level. It will also lead to pulmonary edema, fluid can accumulate. You could also have what we call resistance to infection. So you need to monitor for decreased resistance to infection if you are giving your steroids to the mother. The steroids are also given to the mother, not the baby. Okay, because we have the steroids and we have the I think I also forget the lung surfactants. Okay, under the surfactants. So we have the steroids and we have the surfactants. The surfactants are given to the baby after delivery, but the steroids will be given to the mother whilst the baby is still in the uterus to help with lung maturity. Then, so I've talked about the mother having increased glucose level. If you give the steroids, you could also cause some form of fluid accumulation because of the effect that steroids will have on sodium, and then resistance to infection. So if you are giving this, then, okay, someone I should come again with the therapeutic level. I'm saying that if you are giving medication, let me finish before I go back to that. Okay, let me finish the steroid. So with the steroids, we will talk about, of course, we're saying that it could affect fluid status. So it means that hypertension is one of the things that can happen whilst you are giving your steroid. So you need to monitor vital signs and infection as well. You monitor lung sounds, edema and all that. WBC count, you need to monitor that. Glucose level, you need to monitor that. Then you have to also administer this by IM to the mother. So what I said on the therapeutic level for what we call magnesium is that the serum magnesium level is 1.2, so 1.5 to 2.5. That is the serum magnesium level, normal serum magnesium level. For someone who is not taking magnesium, okay, or not having issues with magnesium, that should be your normal serum level. Now, the moment we start giving you magnesium, okay, for, whatever purpose we are giving, we don't expect your magnesium level to remain the same. And because we are also giving the medication, the level will also go above the serum, the normal serum one we all know. So we now look at the therapeutic level. So if you are now giving max sulfate, we now pair your serum therapeutic level at 4 to 7.5, 4.0 to 7.5. Okay, so if you are on max sulfate, we will not be looking at 1.5 to 2.5. We will now be looking for 4 to 7.5. So if you exceed 4.5, sorry, if you exceed 7.5 whilst you are on magnesium sulfate, that is when we say that you are having magnesium toxicity. So, Madam Vivian, I don't know if that helps with the understanding now. Now, the next class of medication we'll talk about is what we call the oxytocin. Oxytocins are uterine stimulants, okay? They help with uterine contraction. And I've talked about oxytocin several times whilst I was doing math, that oxytocin will help with smooth muscle contraction and will produce force, frequency, and duration of uterine contraction. Oxytocin also has effects on breast milk, especially during the postpartum period. It will help with, letting down of the breast milk, and then so that is the importance of oxytocin in the postpartum period. Oxytocin is used for induction of labor, given via IV routes. It can also be given sublingual, and all the other routes are also available. I won't go into that. But magnesium sulfate should also be readily available. So we'll say that the antidote to oxytocin will be max sulfate, because when max sulfate or when oxytocin is producing effect in excess, you would need your max sulfate to come in to relax what we call the uterus. minimal cervical changes usually is noted until the active phase of what we call phase of labor is achieved. It helps to induce or augment labor. I think I've talked about controls bleeding in the postpartum period, and then also help to manage abortion or incomplete abortion. The adverse effect of oxytocin is that some people are allergic to it. So you have to, adverse effects include allergies, dysrhythmias, changes in blood pressure. Then it can also cause uterine rupture, especially if you give high doses of it. It could lead to excessive contraction, which could lead to rupturing. Water intoxication could also happen out of it. So oxytocin may produce hypertonicity, which will further lead to the uterine rupture if it occurs. High doses may also produce hypotension and later a rebound hypertension. You could also have postpartum hemorrhage. Postpartum hemorrhage can occur and should be monitored for, because the uterus may become atonic when the medication wears off. Yes. So when you are giving your medication, you have to monitor the uterine contractions and all that. Oxytocin should not be used in clients who cannot deliver vaginally or in a client with hypertonic uterine contractions. Okay. If the uterus are already contracting, why would you go ahead to give your oxytocin again? And remember, it is also contraindicated in people with active herpes. When we're doing the touch, I talked about the fact that if someone is having active herpes infection, you wouldn't allow the person to go through normal spontaneous vaginal delivery. And so that means that if you are giving this during active herpes, the probability that contractions will go ahead and then, vaginal spontaneous delivery will be imminent is also high. So you have to avoid it whilst there is active herpes infection. Definitely a cesarean birth will be the appropriate way to deliver the baby for this woman. You have to assess the vital signs of the mother every 15 minutes. You have to also, especially blood pressure, because we said that toxicity can lead to hypotension and a rebound hypertension as well. Heart rate could also be affected, urine output and all of that. Level of consciousness, you need to monitor that. Then, uterine contraction, you need to monitor the frequency they falls every 15 minutes while the person is taking oxytocin infusion. Then you monitor the fetal heart rate or the fetal status. We've done the various fetal heart rate assessment. And so if you notice any changes, you need to inform the healthcare provider immediately. The medication is administered via IV infusion via a pump, so that you can monitor what we call the rate very carefully. Then carefully monitor for the dose being administered. You do not leave the client unattended whilst you have your oxytocin in place or infusion ongoing. Oxygen may be needed. So when you look at the various abnormal fetal heart rates or the non-reassuring fetal heart rate patterns we talked about, we said that oxygen plays a very important, so oxygen administration might also be needed. You monitor, Rosina, kindly mute that for us. You monitor for hypertonic contractions and non-reassuring fetal heart rates as well. You stop the medications if hyperstimulation also occurs or non-reassuring fetal heart rate occurs. You have to administer oxygen as well for that. Water intoxication, you need to monitor. You have your emergency resuscitations equipment at the bedside to assist if there is a need for you to do that. The next thing we'll talk about is methagonavine. Okay, this medication helps to stop bleeding. Okay, when we're doing postpartum hemorrhage, I talked about it that we give this medication to help with contractions, and also it produces what we call vaso occlusion, or it helps with vessel occlusion to stop bleeding. So this medication directly stimulates uterine muscles and increase the force and pressure of contraction, produces a firm tonic contractions of the uterus. It can produce atrial vasoconstriction and then vasospasms of the coronary artery. It is useful in postpartum hemorrhage, and then it also post-abortal hemorrhage resulting from atony or in subinvolution or involution. The adverse effect of this medication is that hypertension is one of the key things you need to monitor whilst you are giving this medication, because of the vasoconstrictive nature of the medication or the vasoconstrictive effect of the medication. It can lead to hypertension. So if someone is already having high blood pressure or is known hypertensive, you have to be very careful when you are using this medication. So it can cause nausea, uterine cramping, bradycardia can also happen, this weakness, myocardial infarction, and then severe hypertension. High doses are also associated with peripheral vasospasms. Then we also vasoconstriction, angina, and all those things. Respiratory depression, seizures, unconsciousness can also lead to uterine tetany. Can also, where you have hyper contraction of the uterus. Contraindicated during pregnancy. So you can't use this during pregnancy. And in clients with significant cardiovascular diseases like peripheral artery disease or peripheral vascular diseases or hypertension. So let's understand that this cannot be used in women who are pregnant, but it is useful in the postpartum stage to help with contraction and stop bleeding. Vital signs are important things. Hey, who's writing on my screen? Kindly clean it for me, okay? The one writing, okay? So you have to monitor the vitals, especially hypertension, level of consciousness, and lung sounds as well. We have to withhold the medication if you note that the client is having what we call hypertension. You have to monitor uterine contraction. You assess for chest pain, headache, shortness of breath, anything that could tell you that there is an adverse effect of the medication. You need to hold it up. Assess the extremities for color, warmth, movements, and then pain. You do vaginal assessment for bleeding. You have to notify if chest pain or other adverse effects also happen. You can administer your analgesics as prescribed. They may be required because the medication can also produce painful uterine contractions. Check the blood pressure before administering methagonavine. Then the medication can cause severe hypertension and then contraindicated in hypertension, like I did say. So for this medication, you are looking at hypertension when you see it being administered or being prescribed to a woman. The first thing you spot when you are reading about methagonavine is hypertension. The moment you spot that there is an indication of hypertension whilst this medication has been prescribed, you quickly have to inform the healthcare provider of that. Then the surfactants are given to the baby, especially those who are born as preterm. You give the lung surfactants to also help, prevent respiratory distress syndrome. This medication is given via the intratracheal routes. Okay. Remember, we said that the steroids are given to the mother. There is a question I've made several times on who to give both the lung surfactants and the steroids. So the steroids are given to the mother, and then the baby takes the surfactants upon delivery. It helps to prevent or treat respiratory distress syndrome in premature newborns. The adverse effect of this is that it can produce some form of transient bradycardia or oxygen desaturation. Pulmonary hemorrhage can also occur. Mucus plugging can occur. And then endotracheal tube reflex can also occur. Surfactants are administered with caution in newborns. because of risks of circulatory overloads. The next thing, I'm just getting to the near part of, or the ending part of my medication, is your epidural anesthesia or epidural block. So epidural blocks are given to, yes, I know time is up because I left with some few things. I'll do that, okay? So give me some few minutes to finish it up, okay? I know it is time, okay? Your epidural blocks are also given to manage pain, okay? In the postpartum or during labor, we give the epidural block or regional anesthesia. The one main thing I want to talk about with the regional anesthesia or the epidural block is the fact that it inhibits what we call sympathetic nervous system. Oh no, I'm not speeding, okay. I'll I'll slow down for you. Regional anesthesias or epidural blocks are used to manage pain during labor, okay? And what it does is that it inhibits what we call sympathetic nervous system. You know that the sympathetic nervous system produces vasoconstriction and help to raise the blood pressure up. But if the sympathetic nervous system is inhibited, it's going to lead to vasodilation. So one of the main things you monitor is what we call hypotension. Okay, hypotension is one of the key things you monitor when you are giving epidural anesthesia or block. So if a client exhibits hypotension whilst epidural block or anesthesia is given, you have to position the client on the left side, okay, on left lateral. IV fluids are also important. You need to give. Then, so in a case of hypotension, when epidural block or anesthesia is given, you have to initiate what we call your nursing intervention should be IV fluids, and then client positioning to the left lateral. The left lateral position will shift the pressure of the uterus off the vena cava, which will lead to a drop in the blood pressure and then also promotes what we call venous return and then improve cardiac output. Now, it can also lead to what we call vomiting, or another side effect of epidural anesthesia is vomiting. When vomiting occurs, one of the emetics that are used in NCLEX, or you come across it in your NCLEX, is ondansetron. So someone said that if someone is vomiting we use ondansetron. So ondansetron, which is also Zofran, is antiemetic that are used to relieve nausea and vomiting if epidural block or anesthesia is producing what we call nausea and vomiting. If hypotension persists or fetal distress occurs, you can administer vasopressors. So the vasopressors are the epinephrine and then the epinephrine, ephedrine, which is an epinephrine in nature. What it does is that they are vasopressors, so they presses on the blood vessels and then cause vessel constriction and then promotes or increases the blood pressure of the individual. You can also give what we call your oxygen, and then to see as to whether, together with your IV fluids, to see as to whether the blood pressure will improve. The last but not the least of my class is on narcotics, when to give your narcotics when you are managing labor. So in labor, we can give narcotics, but the time of administering the narcotics are very, very important, in a sense that the narcotics or the opiates can cross the placenta barrier, especially when you give the medication close to the time of labor, or when labor is, you know that, let's say in about 30 minutes time, the person is likely going to put to bed or the person is going to deliver. That period, you can't give your opiate, because when you give your opiates, by then the medication might have peaked and then could cross the placenta barrier and then affect the respiratory status of the baby, or can lead to opiate toxicity in the baby. So we give what we call opiates during the active phase of labor, when labor is peaking, or when active phase of labor. That is when you give your narcotics. And then it is also said that, or it is also noted that when contractions are strong, the medication stays in the blood, produce the needed effect, and then it's not able to cross the placenta as well. So let's just go through what I have here. The narcotics, examples of it would have the butorphanol, imiperidine, and nalbuphine, which are some examples of narcotics that the NCLEX, they like bringing them up. So you can give this during peak of contraction and can help decrease sedation of the fetus, and then subsequently prevent newborn respiratory distress or depression. Uteroplacental blood flow is significant and then reduces what we call reduces during contraction peaking. So that is why I was saying that at the time when contractions are peaking, blood flow, through the placenta kind of drop. And so the likelihood of medication crossing the placenta barrier is very low. So you have the medication staying in the system and producing the needed effect. In addition, you also have a higher concentration of the medication remaining in the maternal vasculature, which increases the effectiveness of the pain relief. Narcotics do not inhibit what we call contractions, and so labor can progress as supposed to progress, especially in the active phase. It is only when you give it during the latent phase, that is when narcotics or pain medication can affect what we call contraction. But when labor or contractions are well established in the active phase, the narcotics or the pain medication do not affect what we call contractions. And like I said, make sure that the medication you are giving, you do not give it 30 minutes to labor, or when you know that the client has passed the transition phase. You cannot give your opioid, because when you give the opioid, the likelihood that the woman will deliver after transition phase is just maybe in about 30 minutes, the woman can give birth. So you make sure that you are giving your opioid when the woman have about 2 to 4 hours to deliver. So when you know that the woman is likely going to deliver in about 2 to 4 hours, then you can now give your opioid, because the opioid will peak in about 30 to 60 minutes. And so by the 4-hour time, or by 4 hours time, the medication might have worn off from the system. So there is no chance that the medication can cross the placenta barrier, leading to respiratory depression in the newborn. If IV opioids are safe for clients who will give birth 2 to 4 hours after administering, so that the opioids effect has time to wear off before birth. IV opioids are also best for clients in active labor or those with a well-established contraction pattern, because opioid administration may also slow labor progression in latent phase. So the essence of us understanding this is that when you have a question and the client has been prescribed a certain opiate, you have to look at the time the opiate has been given, and you have to look at the stage that the client is within. Is the client in the active phase? We've talked about active, latent, and transition. Is the client in the latent, transition, or active phase? We're saying that active phase is the best time to give your opiates, because that time you could have the medication staying in the mother's vasculature and producing the needed effect, and the likelihood that it will also wear off before actual labor or before the woman delivers is also high. And so it will not also affect what we call the respiratory status of the infant, or will not cross the placental barrier, leading to respiratory depression. This is my last thing: medication to avoid in pregnancy. At least if you forget anything about, not your ACE inhibitors, not your ARBs. So your ACE inhibitors are medication that ends in pril. They are antihypertensives. So lisinopril family. The ARBs are your carbazepam families. Then NSAIDs are also generally not to be used in pregnancy. Phenytoin, lithium, valproate, isotretinoin, and then methotrexate are all not to be used during pregnancy. Warfarin, doxycycline. Actually, they will say that antibiotics are generally not to be used in pregnancy, especially in early sizes. So, but when there's a need for antibiotics, we use. But for the cycling, especially, it should be contraindicated or should not be used during pregnancy. So these are key medications that you should avoid it being used during pregnancy. So this is the last thing I'll talk about, and I'll drop my class here and bring the class to an end on what we call maternity. If you have any question, sorry for going about 20 minutes or 22 minutes into the stoppage time. If you have anything you want to add up, you can bring it up as well before I drop the class here for today. Thank you for staying with me. Thank you for your input. Should we do 1 or 2 questions before we end? Yes or no?
Yes. Yes.
The time
Yes,
is
sir.
hot now. So
Yes.
if you want us to drop it here, we can just drop it. But if you want us to go through some questions, we can do that. Okay. All right. So it seems others want us to do. So let's do that. Okay. All right. 1 or 2 questions, and then we go ahead and close the class. The nurse is monitoring a client who is receiving oxytocin to induce labor. Which assessment findings would cause the nurse to immediately discontinue the oxytocin infusion? Is SATA, select or that apply? 1, fatigue. 2, drowsiness. 3, uterine hyperstimulation. 4, late decel of the fetal heart rate. 5, early decel of the fetal heart rate. Yeah, are we answering? Yes, I'm waiting for your answer. So we are still going through it.
Can you select some?
Yeah, it's SATA. So even if you think the answer is it's only 1, you can go for it.
Okay, I'll go for uterine hyperstimulation. Hyper means like excessive. If you are using oxytocin, you should monitor the uterine contraction. So hypertonia can lead to uterine rupture. So I think uterine hyperstimulation, and then drowsiness as well. If the patient's a pregnant woman in labor becomes drowsy, it means that CNS might be depressing or
Let's go.
yeah. So me, I'm taking 2, I'm taking 3. As for deceleration, maybe I need to consult. I'm coming.
Okay, so she has given us, she said she's going for TV for now. Or you
And
added the
2.
drowsiness to it.
Yeah, I've added 2 and 3 for now.
Okay, all right. I saw
Please,
a hand up. Okay, go ahead.
Hello.
Yeah, Madam Vivian, go ahead.
Okay, so I'll go for 3 and then 4.
3
But
and 4.
4,
Okay.
yes, late deceleration. So it's placenta insufficiency. So I need to stop the oxytocin. But the rest, as for 5, is not part. But
Okay.
the 1 and 2, I'm not sure. So I'll go for 3 and 4.
Okay. All right. Is there anyone with any other thing in mind apart from what our colleagues have said? Mr. Idrisu, if you're muted, are you coming on board?
I'm also considering 2, 3, and
2,
4.
3, and 4. Okay. Okay. All right. Let's see what we have. So we have 3 and 4. Okay. We have 3 and 4, which are there. So we have uterine hyperstimulation and late decel. So these are the things that will make you to immediately discontinue the oxytocin. Drowsiness, fatigue may be caused by labor, not necessarily the effect of oxytocin. Wow. So see what the NCLEX they can see. So yes, there could be drowsiness and fatigue, but that could be as a result of the labor, the labor experience or the stress from labor, and not probably from the medication. But the oxytocin, if there is an adverse effect of it, will lead to hyperstimulation or hyper stimulation and then late decel. Okay. A pregnant client is receiving max sulfate for max sulfate for management of preeclampsia. The nurse determines that the client is experiencing toxicity from the medication if which findings are noted on assessment is select all that apply. We have 1, proteinuria, 2, respiration of 10 beats per minute, 10 breaths per minute, 3, presence of deep tendon reflexes, 4, urine output of 20 ml in an hour, 5, serum magnesium level of 4. Yeah, so let's go through 4 microgram is it MEQ per liter? Milli. Yes. 2, 4. Someone is going for 2, 3. Someone think she will maintain with 2. Okay. Yes. Just fast, then we close. Okay. I know I've taken almost 30 minutes of your time.
Yeah, hello, boss. It's 2, 4.
It's 2, 4.
So usually when there's toxicity of max off, you made mention of a depressed respiratory rate that is less than 12, and that of absent deep tendon reflexes.
Okay.
Yeah, and the urinary output less than 30.
Okay.
Yeah.
Okay. All right. So let's end here. Okay. I know that we've talked a lot, or I've talked a lot. Okay. Thank you for coming. We've done about 2.5 hours. Tomorrow we'll continue, and then we'll know what we'll do for tomorrow. So that will be that for today. Remember, you have to continue to study.